Hey there! Welcome to our session on evidence-based practice, or EBP for short. This is a small but mighty section on your certification exam. It's only about 1% of the questions, but don't let that fool you. These concepts show up across the entire test, so understanding them well will help you in multiple sections. Let's get you ready to nail those exam questions. So, what exactly is evidence-based practice? At its core, EBP is about combining three key elements: the best research evidence available, your clinical expertise as a provider, and your patient's values and preferences. It's not just about finding research, it's about applying it thoughtfully. On the exam, they'll expect you to understand how EBP differs from just reading research papers. The certification folks want to make sure you know how to integrate evidence into real NICU practice. EBP hasn't always been the buzzword it is today. It's evolved over time as healthcare has changed. There are several factors that pushed EBP to the forefront. For one, we now have way better access to research databases than we did even 10 years ago. Patient safety has become a much bigger focus, and reimbursement is increasingly tied to quality outcomes. All these pressures have made EBP more important. As a nurse leader, you're actually in a perfect position to lead EBP initiatives in your unit. Remember that MSN education includes standards about translating knowledge into practice. If you're working on your DNP, you'll complete a project focused on clinical scholarship and analytical methods. Both crucial for EBP, the exam might ask about your role in leading evidence-based changes, so keep that in mind. This is a really important distinction that often shows up on the exam. Research and EBP are related but different. Research is about generating brand new knowledge. It's what creates the evidence we use. EBP, on the other hand, is about taking that existing knowledge and applying it in clinical practice. Think of research utilization as the first bridge in closing the gap between research findings and actual practice. But it's just the start. True EBP goes further by incorporating your clinical judgment and your patient's unique situation. On the exam, they love to test whether you understand this difference, so remember, research creates knowledge, EBP applies it. This slide outlines the levels of evidence, which are essential for understanding EBP. The hierarchy goes from strongest, level 1, to weakest, level 7. Let me break it down. Level 1 is the strongest. Meta-analyses and systematic reviews of randomized controlled trials. Think Cochrane reviews. Level 2 is a single well-designed RCT. Level 3 includes quasi-eye experimental studies. These aren't fully randomized. Level 4 covers non-experimental studies like case control and cohort studies. Level 5 is systematic reviews of qualitative or descriptive studies. Level 6 is single descriptive or qualitative studies. Level 7 is the weakest, expert opinion, case reports, or committee statements. You will probably see at least one question asking you to identify the strongest or weakest evidence for a clinical situation. When you're looking for evidence to guide practice, you don't have to start from scratch. There are excellent pre-appraised sources out there. The Cochrane database of systematic reviews is the gold standard. It was established back in 1993 and contains independent, high-quality reviews. Clinical practice guidelines are another great resource. For neonatal care specifically, check out the NAN guidelines for skin care, pain management, and PICC lines. These might be referenced on the exam. You should also be familiar with some common EBP models, like the Iowa model, ARCC, Johns Hopkins, and PARiHS. These provide frameworks for implementing evidence in practice. While I don't think you'll need to know the details of each model for the exam, knowing they exist and their general purpose is helpful. The exam expects you to understand the overall EBP process, which follows these steps. First, you identify a clinical question based on something you've observed in practice. Next, you search for relevant evidence in the literature. Then you critically appraise that evidence. Is it good quality? Is it applicable? After that, you integrate the evidence with your clinical expertise and the patient's values. Then you implement your evidence-based intervention. Finally, you evaluate the outcomes to see if it worked. This logical progression is important to understand for the exam. It's a circular process. Evaluation often leads to new questions, starting the cycle again. Formulating a good clinical question is the foundation of EBP, and the exam will likely test you on this. The basic format is PIO. P stands for patient or population. Who are you concerned about? I is for intervention. What are you considering doing? C for comparison or an alternative treatment. O is for an outcome. What result are you hoping to achieve? You might also see PICOT, which adds T for time frame. Let me give you a NICU example. In very low birth weight infants with stage 2 NEC, P does adding clindamycin to ampicillin, I, reduce mortality, O. See how that clearly defines who we're treating, what we're considering, and what outcome we're looking for. The exam might ask you to identify well-formulated clinical questions, so practice recognizing them. Once you have your clinical question, you need to find evidence efficiently. The exam won't test your database searching skills specifically, but understanding the process is important. A good search strategy starts with systematic reviews. Checking the Cochrane database first is smart. Then you might move to medical databases like PubMed. In PubMed, the Clinical Queries feature can help focus your search on therapy, diagnosis, or prognosis. Remember, you're looking for the highest level of evidence available to answer your question. For treatment questions, RCTs provide the strongest individual study evidence. The exam might ask you to identify appropriate search strategies for different types of clinical questions. The exam recognizes that implementing EBP is often an organizational effort, not just an individual one. There are some key differences between individual and organizational EBP. When you're working within an organization, you'll often use a formal model like the Iowa model to guide implementation. You need to assess your specific site's needs and resources before implementing a change. Staff training and support are crucial. The best evidence in the world won't help if your team isn't on board. Evaluation strategies need to be planned from the beginning. The certification exam might ask you to identify appropriate steps for implementing an evidence-based change in a NICU setting. This is another important distinction for the exam. Quality improvement, QI, and EBP are related but different. QI focuses specifically on improving patient safety and care quality. While EBP can be done by individual practitioners, QI typically requires a team approach. QI often uses internal performance data, while EBP primarily uses external research evidence. QI typically happens within an organization and involves measuring, benchmarking, and comparing outcomes. The exam might test whether you can distinguish between these approaches. For example, if you see a question about using Vermont-Oxford network data to improve your unit's performance, that's QI territory. Quality improvement follows a structured process, which is good to understand for the exam. First, you identify specific aims and priorities. What exactly are you trying to improve? Process mapping helps you understand all the steps in a care process and where issues might arise. You'll need evidence for your interventions. This is where QI and EBP overlap. Implementation involves making changes to practice. Measuring outcomes tells you if your changes are working. In the NICU, common QI focus areas include reducing BPD, IVH, or ROP rates. The exam might ask you to identify appropriate QI priorities or processes for a given scenario. PDSA cycles are the bread and butter of quality improvement, and they will definitely show up on your exam. PDSA stands for Plan. Develop a specific change based on evidence. Do. Implement that change. Study. Collect and analyze outcome data. Act. Evaluate results and decide whether to adopt, adapt, or abandon the change. These cycles are meant to be rapid. You test a small change, measure results, then refine or expand based on what you learn. The exam might ask you to identify the correct sequence or components of a PDSA cycle, so make sure you know this framework well. The exam recognizes that implementing evidence in practice isn't always smooth sailing. There are common barriers you'll encounter. Leadership commitment is essential. Without it, changes often fail. Staff engagement across all shifts is crucial. Night shift can't be left out. Communication strategies need to be robust. Resources, time, money, staff need to be allocated appropriately. Resistance to change is natural and needs to be addressed. The exam might present scenarios where these barriers arise and ask you to identify appropriate strategies to overcome them. Let's review the key points you need to remember for the exam. First, know the definition of EBP, integrating research evidence with clinical expertise and patient values. The levels of evidence hierarchy is absolutely critical. Memorize it. Understand how to formulate PICO questions. Know the differences between research and EBP. Understand the quality improvement process and how it differs from EBP. Be familiar with PDSA cycles and their components. These concepts make up a small percentage of the exam, but understanding them will help you with questions throughout the test.